Okay, Aaron, what did you show? Oh yes, this is actually now I figured it out. So let's go to the top left and go higher mag on that area. This should also be like almost a spot diagnosis. There's something at low mag that you should recognize in there, and then go higher, Aaron, and leave it. Yes, yes. So Frido, tell them why you thought of that, and Aaron, flip in the condenser for a second and just get the focus. Yeah, get the focus right. So why did you think of that?
We have spindly cells and this type of hyalinized background.
Yes.
Which they have a name for ropey collagen.
Yes, ropey collagen, actually also seen in SRI, right? Dense ropey collagen. But yeah, that's correct. So the way I think about solitary fibrous tumor is, if you think of a benign spindle cell lesion that's making you think about a schwannoma or a leiomyoma, if that's what's going on in your head, you should be thinking also of solitary fibrous tumor. So especially in the lung. Now, can somebody tell me how it looks like? How does it present radiologically? Where do you find it inside the lung?
Neural-based nodule.
Is it multiple nodules or single? Does it make a rind around the lung and surround it, or is it just one?
No.
Yeah, just one. It just sits on that like a seborrheic keratosis. It just pops out from the top of it. And they can be very big, but they are always on the surface. And for that kind of presentation, there's really the first thing to think about is solitary fibrous tumor. Like out of 100 cases of that kind, 95 of them will be solitary fibrous tumor. So if you know that's pretty much done. And this ropey collagen is a very good clue. I think of it as like between the cells. So you see there's a cell here and then a cell there, and the collagen is in between. There's a cell here and a cell there, and the collagen is between. That's a really, really good clue. And do you guys know the stain that we should do? Yes, STAT6. And when I was a resident, there was no STAT6. We used to do CD34 and BCL2 and that nonsense. But now that we have STAT6, we don't have to worry about all that. We just, it's so much easier to read and better. Okay, next case. We'll do 5 more minutes of the fast one, and then I'll tell you guys if you want to go slower, we can go slower. All right, Aaron, all yours to show the lesion. What kind of a specimen, guys? Anyone? What kind of biopsy? Transbronchial. Very good. Very good. Because it has alveolated lung, right? It's kind of roundish. It's not needle shaped, and so you're in a transbronchial biopsy.
Non-necrotizing.
Yes, non-necrotizing granulomas. And what else do you want to know about these granulomas, Frido? What are you looking for when you're trying to run through what this can be?
The location of the granuloma.
Where is it?
There's interstitial granulomas.
Interstitial, very good. And that helps,
interstitial,
right?
yeah.
That helps to know that it's interstitial. Because if it were airspace granulomas, the differential would change for that. Okay? So interstitial, and what else did you say?
It's naked granulomas.
It is naked in this case, but it doesn't necessarily help. So there can be lymphocytes around it. That doesn't really change the differential. Anything else? What else helps?
Is it peripheral or central?
Not really. I think the other thing that helps is how does the lung look away from the granulomas. So Aaron, just point at the normal lung down there with an arrow. So you want to look at not where the granuloma is, but away from that, right? And if the lung becomes completely normal, that's actually one of the features of sarcoidosis. That the abnormality is where the granuloma is, but away from that, it's completely normal. In the differentials, let's say hot tub lung or non-tubercular mycobacterial infection or hypersensitivity pneumonitis, the whole lung is inflamed. So even away from the granulomas, there's a kind of a lymphocytic infiltrate, organizing pneumonia. In sarcoid, it just goes normal. In sarcoidosis, the granulomas are interstitial rather than airspace. In sarcoid, the granulomas are well formed rather than poorly formed. And in sarcoidosis, the other thing is that you have a lymphangitic distribution, meaning that the granulomas are along the bronchovascular bundles, interlobular septa, and pleura. But in the transbronch, you won't see that distribution. So that part of it you can't tell. Can anybody tell me what the classic clinical finding is in sarcoidosis? How do they usually present?
Lymph nodes and infiltrates in the lung.
Yes, hilar lymph nodes and infiltrates or nodules, typically small nodules. And what is characteristic about the hilar adenopathy? I mean, lung cancer also has hilar adenopathy. Bilateral, yeah. So it's usually bilateral and symmetric. And it's usually accompanied by bilateral symmetric lung nodules, also in a lymphangitic distribution radiologically. So if you have the classic radiology, the clinical is almost good enough to make the diagnosis of sarcoid by itself. What they want to really exclude when they do this is to make sure they don't have lymphoma, because that's the other thing that can look exactly like that. Young person, bilateral hyadenopathy. But in terms of other mimics, there are few things that look exactly like that clinically. So you're in good shape when you have a granuloma. But the better, more classic it is, the more you have confidence that it is sarcoidosis. Okay, next case. Yeah, so this is sarcoid on a transbronch. Beautiful classic findings. Okay, Aaron. Are you running out of cases? Do you need me to? Okay, good. All right. Okay, what do we have here, guys? Aaron, show them the normal tissue.
Muscle.
Yes, exactly right. Muscle. You've got some fat right down there.
Yeah.
And so we are probably in the chest wall / pleura. In fact, if you're on the chest wall side of the pleura, you're probably in parietal pleura, right? Okay, so show them the lesion, Aaron. And then when you're sure you're in the lesion, just leave it there for a few seconds so everybody can wrap their head around what's going on. We'll need higher mag. Yeah, I would leave it here for a few seconds.
Just like the mesothelioma we saw before.
And move it around a bit. No, yeah, leave it here for a second. So is this benign or malignant, this stuff here? Benign, like fibrosis?
Yeah, there's something in the background.
Yeah,
This
it's
stuff's
very fibrosing, isn't it? So is that what is happening? There's like a fibrosing process, and then there is also a malignancy? Or what, is it malignant or benign?
I think I saw some malignant, gland,
Show them if there's
stuff.
anything that looks malignant.
It's not on this, yeah, there's that stuff looks.
Ah, man, yeah. Can you give us a higher mag of this? Now we know that this stuff is in the fat, right? So this is not going to be benign, this stuff. If it's epithelioid looking, making glands, just add just a little bit, move it up a bit and you'll see those glands. Yeah, see? So that cannot be benign. So if that is malignant, that's the epithelioid portion of the mesothelioma. Where's the sarcomatoid? I don't see it. Do you? So move it back to that fibrosing area. And then just leave it, yeah, like there. One higher mag. Does that look malignant? Anyone? Like, do the cells look malignant?
Not so much.
No, right? They look like fibroblasts. So this part is actually a desmoplastic mesothelioma. That's what it looks like. It's very, very bland cytologically. It is, so all of this is actually malignant. And this is actually biphasic because it has an epithelioid component. But you saw in the previous case, the sarcomatoid looks like a sarcoma. It's clearly malignant. This is a very bland, cytologically bland tumor that infiltrates the chest wall, does exactly the same things as any other mesothelioma, but it looks super bland. So this is the kind of case that is very likely to be misdiagnosed, or even the best pathologists sometimes can't diagnose this because it looks so much like benign tissue. So what are the clues that it's malignant? It's infiltrating into the fat. There is a malignant epithelial component next to it. And then there's other subtle things like, areas of hypercellularity, areas of, necrosis in between it, a storiform pattern. But those things can be very difficult to tell. I mean, it takes a lot of experience to diagnose this in the absence of a malignant epithelioid component next to it. All right? So this is a biphasic mesothelioma with a desmoplastic component.
So if you only had this, would you only do cytokeratin or D240?
Yes, the other stuff is unlikely to be positive in this. The mesothelial markers are extremely unlikely to be positive. So what you would want, if you only had this, is you would want to see invasion into the chest wall or fat. You want to see keratin positivity diffusely through this thing, and you want the classic clinical features. You want a generally elderly person with a rind or multiple pleural nodules. And of course, no history of anything else. If you had all that perfect, then you can call it. Otherwise, you want to back away from calling, especially in a small biopsy. Now, when you resect, you see all the architecture and it becomes obvious, but on a biopsy it can be very difficult. Okay, Aaron, great. Ooh. I'll give you guys a second to look at what's going on.
Something going on in the interstitial.
Mm-hmm.
I guess mostly inflammatory cells.
Mostly inflammatory cells.
Looks like a benign lesion.
Yeah.
Benign lesion, right?
There's some fibroblastic foci.
Yes. So that doesn't quite add up, right? Inflammatory cells plus fibroblasts.
Pneumonia.
Okay, so we'll come back to that.
Do we have any areas?
Kind of like an ill-formed granuloma maybe there. But so go back again, Aaron, to Lomac.
Do we have honeycomb change anywhere?
Let's see, yeah. So exactly, you want to see at low magnification what is really going on in terms of the pattern distribution. So you see there is actually, stop here Aaron, for a second. This is actually scarred lung. It is scarred, meaning that the architecture is all distorted. Yeah, and just get it into focus. There's architecture that's distorted here. There's no architecture up there, no architecture there. Now move it to the left a little. No, the other way. And show me that. You see, it goes to completely normal here. So that is the so-called
Facial.
patchwork. Yes,
Yeah.
heterogeneity. Is you get a patchwork, meaning they're completely normal, and go back to the scarred again, Aaron, to show them. And then you go to architecture that's distorted, and then go to the right. And then you might get areas that are more like NSIP-like and so forth. Like here, go up there. Like more diffuse here. Diffuse interstitial abnormality. But then there's a patchwork. There's scarring to the right. So this is actually UIP. And then the fibroblast foci. So Imad, to answer your question about if you can just find a fibroblast focus, Aaron, we'll talk about that. Yeah, well, this is not the
They're
best.
usually at the.
Yeah, move
border
around.
between-
That's correct. They're usually at the border between the fibrotic and non-fibrotic lung, but they can really be anywhere. They can even be within the, the areas that look normal. I think you'll have to, yeah, you can bring it there.
Yep.
Up here, this guy here. So see, fibroblast foci, there is actually air space here. See where those macrophages are? This is air space. That's the alveolar pneumocytes. See those?
Yeah.
Very prominent. So what's that?
Interstitial.
Interstitial. So that whole fibroblast focus, it's like a dome. It can also have a dome on the other side, or it can be flat. It doesn't have any inflammatory cells in it, plasma cells, histiocytes. So that's one thing that goes against organizing pneumonia. It's in the interstitium, not in the airspace. That's against organizing pneumonia. There's only one lesion in this, like in this field, one lesion. Organizing pneumonia is clustered. So you get one here, one there, one there, one there. Like there's several plugs together. It has a dome shape rather than being like snaky like that or serpiginous. So that's against organizing pneumonia. And plus, now if you back up and see the architecture and the patchwork, that's also against organizing pneumonia. So that's why this is UIP and not OP. Okay? Next case. Okay, we'll do one more fast and then we can do whatever you guys want for the next. Ooh. I'm going to be quiet and let's see if you can get this. Aaron, you can go wherever you want. So I want here, guys, a description before you give the diagnosis, okay? I want you to run me through your thought process, whatever you're seeing.
Interstitial process.
Yes, interstitial process.
High lying material.
Macrophages.
Macrophages where?
In the alveolar.
Yes.
Alveolar spaces, we have prominent pneumocytes.
Yes.
We have
Some
some.
chronic inflammation, 26.
There is a little chronic inflammation here, yes. How about here? Wait a second.
Some acute inflammation also.
Just bring that a little bit, this stuff to the middle. What's on the right now? Yeah, bring that to the middle. Middle, stop. Yeah, like this. What's going on here?
Some eosinophils.
Eosinophils.
Yeah.
What about in the, how does the interstitium look? Go one lower mag.
It's collagen, a lot of collagen in there.
Totally
That's not normal, right?
Yeah,
No.
So, any thoughts about what's going on there? Is it just non-specific? Ignore this and look at the cancer. There's no cancer here. Okay, go back low mag, Aaron. Yeah, and now move it around a little. I'll tell you where to stop. Move it around. Go to the right. Oh, actually you can, yeah, this is good. Stop here. Now come to high mag.
This
And
looks
just
like
flip it in.
SRIF,
What is SRIF?
smoking-related interstitial fibrosis. So fibrosis in the interstitial. That's
Smoking related interstitial fibrosis. So is the fibrosis enough to make that diagnosis, or do you want to
You
see
want
something else?
macrophages as well.
There are three things. It's like a triad that you need to call it smoking related interstitial fibrosis. What was your reason to call it, Frida? What did you
Just
see
the-
here?
Only the interstitial fibrosis. What I said.
How do you know it's not NSIP? It's pretty uniform looking, or amyloid.
Amyloid looking, yeah, could be too.
It's amyloid looking, right? It's very ropey. The collagen is ropey. Aaron, let's do one higher mag and try to show the nature of the and maybe a little bit to the right. See where those wavy things are? Yeah, like that. See, the collagen has those wavy kind of that ropey look, and there are a few inflammatory cells, but very few. Now go back to low mag, Aaron. So the other thing is those macrophages that are in the airspace are smokers' macrophages. If we look at it carefully, they have pigment in them. So that is the second thing of the triad. There must be RB in the background. If there's not RB, it's not SRI. You're probably misinterpreting something else. So it has to have the ropey collagen, the RB, and there's a third thing that always is there with this. Emphysema. Who said that? May, good. So just go low mag, and now try to find an emphysematous area that where you can see that the air spaces are big. Like even those. See, there's a big hole there on top left. Yeah, see that area. So that lung is really emphysematous, and why it's hard to tell that it's emphysema is usually you don't get fibrosis in emphysema. You know, you're not used to seeing big holes in fibrotic lung, but that's actually what this is. This is emphysematous lung with ropey alveolar septal fibrosis. So you got the three components: ropey collagen, RB, and emphysema. Everything has to be together, and then you can call it smoking-related interstitial fibrosis. I don't need to know this patient is a smoker. I know from this triad. Okay. Next, Aaron. So we are back to some kind of resection or big biopsy. Do you guys want me to slow down, or should we keep at this pace? Huh? Fast pace? Okay. Okay, I want you to fill in the blanks. The lesion in this case is a dash.
Circumscribed.
What?
Nodule.
Nodule, yes. You should start like that, you know? It's a nodule or a mass, and we're trying to explain what that is. Good. Now, one high mag here will be enough, and just make it, show them a high mag and leave it there. One like a high, yeah, that's great. And just leave it there with a good focus. Descriptions.
Spindle cell.
Story form.
Yeah, spindle cell, correct.
With
Little bit of a story form, right? Yeah, well, maybe little bit.
inflammation in the background.
Inflammation in the background. Very malignant looking.
No.
Bland. Any mitoses?
No.
Necrosis?
No.
Nothing. All right. What could be your differential in a thing like this?
Leiomyomas, what mesothelioma?
Yeah.
Yes. Do leiomyomas occur in the lung? Primary leiomyomas?
No.
Yes.
Yes.
Yeah, just
Yeah. If it's a leiomyoma in the lung, you have to be thinking it's a met from the uterus, so-called benign metastasizing leiomyoma. So let's just take that out. Say this is a solitary nodule. So it can be
myofibroblast tumor.
What's that?
Inflammatory.
Yes, very good, very good. So you should be thinking inflammatory myofibroblastic tumor, because this is what myofibroblasts look like. One thing Jesse taught me that always I remember in my head is like the myofibroblasts look elongated like taffy. Do you guys know what taffy is? Like it you can pull it and it elongates like that. You know, like almost like chewing gum. Or you can pull it. So that's what the nuclei look like. Very elongated spindle cells, very bland, and there's lymphocytes and plasma cells in the background. Now this could be other things, of course. It could be a desmoplastic melanoma or some other kind of benign spindle cell tumor. So you want a stain that works or some kind of confirmation, right? ALK.
But it's only describing 40% of the cases.
Yes, so ALK can be relatively insensitive. So the one thing you can do is use an ultra-sensitive ALK, which we use for lung cancer, right?
B5F3.
The D5F3, and that picks up a much higher percentage, much higher than standard ALK. So you should know there's a recent paper that says that you can also get ALK positivity with the D5F3 in angiomatoid fibrous histiocytoma. So that's a pitfall, but those usually don't look like this. There's a morphologically different look. So most of the time that's not a problem, and the pickup is higher. Plus you can do another thing, which is ALK fish, and that will pick up in some. One tip is that if you ever get a case like this and you're sending it for fish, make sure you tell them only count the spindle cells. Because otherwise what happens, they will count all the nuclei in this field, and so all the inflammatory cells will be counted, and then the count will drop from like 60% to 6%, and then it will be counted as negative. I've had that happen before. So what you want to do is when you send this for fish, make sure you tell them only count the spindle cells in the fish. Okay? Alright, next case. Great, Aaron. We've got how long? 14 minutes. How many more cases do you guys want to do? I can stop at any point. 2, 3 more? And then end well in time? Okay. Ooh. We're in lung. It's a little bit out of focus, Aaron. You can leave it there, just get it into focus a little. And one higher mag. And just leave it there for a couple of seconds so everybody can see what's going on. Now get it back to low mag again. I kind of like that sequence. You start at low mag, then you go to high mag and get your sense, then come back to low mag again and reassess what, the relationship. So go ultra low mag, Aaron, and just show them what the lesion is doing. Is it a mass? It is, right?
Yeah.
It's in the lung. What's happening at the periphery there? On the top left. That looks different.
Maybe interacting some normal lung.
Yes, very good. So it is a low-grade lesion that is entrapping normal lung. And see how florid and complex it looks, right, when it gets entrapped. So you already know because of that the lesion is probably a sort of low-grade, slow-growing lesion. And just show them the high mag here, Aaron. And flip it in, yeah. What kind of lesion is it? What kind of cells? Spindle cells. And can you guess what this is? Yes, and we're again in a solitary fibrous tumor. And this is now a little more hyalinized looking than the other one. But essentially in the lung, this is what happens. It can get more hyalinized looking, it can have more cellular areas. Rarely the cellular areas can become malignant, and so you can have a malignant SFT. But most solitary fibrous tumors in the lung have a good course, especially if they're small and bland looking like this. Okay? Next case, Aaron? Okay, I want to show you one. Let's do one more and then I'll show you a special, one special case. Ooh, this is beautiful. I know what this is from low mag. So there is something here about the distribution. Just leave it here for a second. Anybody, can you tell me what?
Bronchial or?
Yes. How do you know that? How do you? I don't see a bronchiole here.
Blood vessel is here.
Yes, that's a great point. Great point. I am proud of you for saying that. That's very, very good. So the point is that because you see an uninvolved blood vessel, there must be an involved bronchiole next door. So just point out the blood vessel, Aaron, at the top left. So you know that so arteries and bronchioles go in pairs, right? So there's always next to an artery like that, a bronchiole in the lung. And here that bronchiole is gone. It's destroyed by this inflammatory process. So let's go higher mag on this, Aaron. Let's see if you can pinpoint. Yeah, one higher mag on that.
9 cells.
Ooh, so what is going on there? Yeah, what is that?
A big granuloma.
Yes, it's a granuloma. Go one higher mag at that. Yes, actually bring it into the center and just leave it there. Yep.
There we go.
And of course the lung away from it is just normal, right? All the action is right there. Yeah, one higher mag. Great, leave it. Yes, it's like an abscess. But can you call it an abscess if there's a granuloma around it? No. So an abscess with a granuloma around it is a suppurative granuloma. That's what it's called. So it's a kind of variant of a necrotizing granuloma. So suppurative granuloma, the differentials anybody can give me in the lung? Mycobacteria, less.
Histoplasma.
No, actually, histoplasma has pink necrosis usually, not suppurative, not neutrophil rich. Cat scratch in the lymph node would be right, but not in the lung. Blastomycosis has classically suppurative granuloma. It's of the fungal organisms. If you see this, bang, you know that it's most likely blastomycosis. Wegener's is another thing that does it. Okay, so go one low mag, and there is a. So I'll tell you in this field, there's a finding that is absolutely pathognomonic. It tells you what the diagnosis is. It's slightly out of focus, Aaron.
Within one of the suppurative granulomas is like a eosinophilic ball. Material.
Bring it into the high mag, Aaron. You know what he's talking about? Yeah, that. Maybe it's fibrin. But then that wouldn't be a diagnosis, right?
Maybe it's an organism.
Maybe it's an organism. Anyone?
Oh, it's like a parasite or something.
No. But that's a good thought. Yeah, that could be. Parasites look like that too. Anyone? Why would a parasite be right next to, involving a bronchiole? Bronchiole means it came in through the airway, right? Anybody?
You mean the parasite thing?
Not parasite. It's not parasite. There's something else that's in the differential of a parasite, but that gives you the diagnosis. There's only one thing this could be.
Vegetables.
What's that?
Vegetables.
Yes, this is vegetable material, aspirated vegetable material. In fact, this kind of structure is called a lentil. In the from how you get lentil soup, and people in nursing homes they get because they can't swallow easily, so they get lentil soup. And for some reason, lentils like legumes are difficult to digest, and then they stay in the lung for a long time, and they make this kind of reaction. So suppurative granulomas, there's actually a background of organizing pneumonia, and it can be very easy to confuse this with infections and Wegener's until you see that material in the middle of the granuloma. Okay? All right, one more. I'm going to give you one last case. So Aaron, here, you do it. You do it.
Okay.
I want you to see something classic here. Start off with this slide, then go to this slide, then do not look at these till I tell you to. Okay. I'm going to have this, you guys do it as a true unknown. So let's see how good you guys are. Transbronchial biopsy. Perfect, Frido. I'll give you points just for transbronchial.
Inflammation.
Chronic inflammation. You guys are doing great so far. And I will tell you, there is actually diagnostic finding right in this biopsy, right in this fragment. Infiltrates is the, and it's a relatively young person, about my age, about my age with infiltrates. Give them a high mag, Aaron, and just try to get it into focus. Just move it around slightly, little bit. Go south and stop. And I'll tell you, there's a diagnostic finding in this field.
PCP.
Ooh, who said that?
Oh,
Oh, good job. Was that Aaron?
Yeah.
Yeah. Do you see that? It is very easy to miss. very easy to miss because it's not like the lung is like rip-roaringly inflamed or there's a frothy material. See how the PAP was? It was just obvious. Everything was filled. And they say that PCP and PAP are differentials of each other, but they look very different, you know. This material, so I'll just bring it in and see if you can find, actually just bring this to the center. And there's one at the top too, see there?
Top, yeah.
Bring it to the center so we can look at it more carefully. Yes, and a higher mag. Now just burn that image into your brain because this can be a game changer in terms of the patient's, you know, diagnosis. This can lead to serologic testing, and you know how it can be. You can lead to an HIV/AIDS diagnosis. You can find out the patient is severely immunosuppressed. So this can be a very, very consequential diagnosis. But look at what's happening. The alveolar septa are minimally involved, very slightly thick, a bit inflamed at top right. But the action is in the air spaces, and you have this frothy kind of bubbly material, and in there are the organisms. So I want you, Aaron, to just show now the GMS, and we'll come back to this again. We'll come back. So keep that slide with you.
Okay.
So I have actually diagnosed PCP in practice just on the H&E. I sign it out and do the GMS later because it's such you want to, you know, have treatment start quickly. These patients are hypoxemic, can be very sick. But the diagnosis can be made. Is that the GMS?
Is the one you gave me?
Oh, sorry.
I didn't see messages.
Oh, there. Yeah, yeah.
Here we go.
Okay, so this is the last case, but it's very, very interesting. It looks blue on the...
Yeah, it looks green under the scope.
Okay,
but it's
let's
projected
go to
blue.
HiMac and just show them the organisms on that so they have an idea what it looks like. You'll need the like 40x and yeah, find a that's great. It does not project as well as it looks on the so let's see that. See that, guys? The characteristic thing is these like crescent shapes. Yeah, see those or crushed ping pong ball appearance, crescent shape like that. See these. And the other, so if you combine this with the frothy appearance, there's no differential to this. This is absolutely diagnostic. Okay, now go back, Aaron, go back to Lomac.
On the H&E?
Yes, I'll give you another slide.
Okay.
Why would I give him the same slide back again? We're done, right? We have a diagnosis, we've made the clinician is happy.
But wait, there's
There's
more.
more.
Billy Mays here.
CMV.
CMV. How do we know that, Frido?
There's one cell that has inclusions.
Let's see, I couldn't see it from Lomac.
Of course I
Yeah.
lost it, but I saw it.
Yeah,
There it
this one.
is.
Yes, go to that at HiMac. Yes, so what you're seeing here is, it's still out of the field, I think.
Yep.
Yes, it's a big cell, right? Cytomegalovirus. And then there's an inclusion. See that smudgy thing in the nucleus? That's the inclusion, nuclear inclusion. And then see the stuff in the cytoplasm, those little granules? Those are cytoplasmic inclusions. So there are virions in there too. So the important thing, the message I want to tell you is when the patient is severely immunocompromised enough to have PCP, look for a second organism. I have seen in a cytology case 3 organisms in the same slide. Histo, PCP, CMV in the same slide. So that's the message I want to give you, that if severely immunocompromised people can have more than one infection, so never forget that. You'll be very happy that I made a great diagnosis of PCP, step back and say, go back to the slide again. So last slide and then we stop, because I'm going to show you the CMV immunohistochemistry. It's on the piece that's a little bit covered with a, I don't know, with a, yeah, right there. No, there are better ones, like full-fledged dots. Maybe it's not that piece. Yeah, there. See, so those nuclear things that are enlarged are marked beautifully by the CFB immunohistochemistry. You guys must have seen this in GI and stuff like that. But in the lung also it works beautifully to confirm the diagnosis that this actually is CFB. Got it, guys? Okay, thank you very much. Thank you for attending. Thank you for being part of the